Hello, I am Arvind Dasari. I'm an associate professor in the Department of Gastrointestinal Medical Oncology at MD Anderson in Houston, Texas. I will be talking about the management of colorectal cancer in this year in review session. We'll first start in the neoadjuvant setting in the management of uh, colon cancer. The phase 3 NeoCol study compared neoadjuvant chemotherapy versus upfront surgery in patients with locally advanced colon cancer. This trial enrolled clinically staged T3 with an invasion depth of about 5 millimeters or more, or T4 with or without lymph node involvement, and obviously no metastatic disease. The trial enrolled close to 250 patients who were randomized 1-to-1 to upfront surgery versus neoadjuvant chemotherapy followed by surgery. The neoadjuvant chemotherapy was Kpox for 3 cycles or FOLFOX for 4 cycles. And further adjuvant therapy in both arms was based on the pathological stage. The primary endpoint of the study was disease-free survival, and there were several secondary endpoints. First, starting with the patients who were enrolled onto the trial, and actually looking at the group that went to surgery immediately without neoadjuvant therapy. The reason I picked this group is to see whether the staging that is done by CT is accurate and how well it matches up with the pathological stage. And I pulled out some of the key numbers on the left bottom panel, where you can see that there are some discrepancies between the clinical staging versus the pathological staging. And similar concerns were also raised on the Foxtrot trial that also asked a similar question. So that's something to keep in mind, that CT is not really accurate at determining T or end stage. Looking at the primary endpoint of disease-free survival, there was no improvement in disease-free survival with the addition of neoadjuvant chemotherapy. However, as to be expected, the patients who received neoadjuvant chemotherapy actually required less adjuvant chemotherapy, and there was also downstaging of their tumors with neoadjuvant chemotherapy. So, takeaways. Neoadjuvant chemotherapy does not really improve disease-free survival as compared to standard upfront surgery followed by adjuvant chemotherapy. We do need to be cautious about the risk of overtreating these patients, and CT scans may not be very accurate in determining the actual stage. This is a study that was designed many years ago, so these patients did not have MSI testing or ctDNA testing done. Those are some of the limitations of the study. So, what is the takeaway from the study? I think this and the Foxtrot study show that neoadjuvant chemotherapy is safe and can be done when needed. And which would these patients be? These would be patients with very locally advanced disease, so T4, T4B lesions, to try and downstage their tumors to make resection easier. But there's no clear benefit to really recommend doing this on a routine basis in most patients that we see every day. Keeping with the theme of neoadjuvant therapy and looking at neoadjuvant chemotherapy, but moving a little lower down, looking at rectal cancer patients, the Prospect trial evaluated preoperative chemotherapy with selective chemoradiation in patients who did not have adequate response to preoperative chemotherapy versus the standard of care, that is chemoradiation for all these patients. The key inclusion and exclusion criteria are listed below. So these patients had uh, fairly early stage mid to upper rectal tumors. So these patients were candidates for sphincter sparing surgery. They should not have required an APR. And they should have had a T2N plus or T3N minus or plus tumors. However, the lymph node involvement had to be limited, and with less than or equal to 4 pelvic lymph nodes and less than or equal to 1 centimeter in short axis. And these patients were randomized to the standard of care of chemoradiation, followed by surgery and adjuvant chemotherapy versus upfront chemotherapy with FOLFOX for 6 cycles and then restaging. And adequate response was defined as at least 20% improvement in the tumor. And those patients who had at least 20% improvement went to surgery, skipping chemoradiation. And those who did not had pelvic chemoradiation prior to surgery. Looking at the patient characteristics who were enrolled onto this trial, like I mentioned, the tumors were mid to upper rectum. So the median distance from the anal verge was 8 centimeters for these patients. The vast majority of patients had T3 disease, and about 40% or so were node negative. This trial was, as I mentioned, looked at the selective use of chemoradiation in patients who did not have adequate response with neoadjuvant chemotherapy. And in fact, only 9% of the patients who received chemotherapy actually received chemoradiation, suggesting that this is pretty effective to do neoadjuvant chemotherapy. And the trial was with a non-inferiority design and showed that the selective use of chemoradiation preceded by chemotherapy was indeed non-inferior to upfront chemoradiation in everybody. The disease-free survival rate at 5 years was comparable between the two arms at around 81% versus 79%. Furthermore, looking at other key outcomes, such as the risk of local recurrence, it was very, very low in both arms. As you can see, the local recurrence-free rate was over 98%. Overall survival was also very high and comparable between the two arms. What was really intriguing in this study was the PAT-CR rates, even with just chemotherapy, was around 22%, and with chemoradiation was 24%. So again, very comparable between the two arms. So in summary, what this study showed and validated was that in patients with mid and upper rectal tumors with CT2, 3, and without extensive lymph node involvement, upfront FOLFOX may be done to omit radiation safely and effectively. And this trial actually validated, as I mentioned, what we've already been doing for a few years. So it's very reassuring to see that. So takeaway, I just wanted to summarize very quickly the current approach to locally advanced rectal adenocarcinoma, taking into account not just this study, but also a few other studies that we've heard of over the last 2 to 3 years. Every patient with locally advanced rectal cancer should be accurately staged. And in most patients in the US, that would be with a pelvic MRI, although an EUS may also be used. And these patients should also get microsatellite testing done. In patients who are MSI high, it's very reasonable to use immunotherapy. And in fact, that's in the NCCN guidelines currently. In patients who have upper rectal tumors with very early stage disease, say T2 or maybe early T3, without any lymph node involvement, perhaps you could think about upfront surgery and adjuvant chemotherapy as needed, or these patients could also be treated with chemoradiation. In patients who have upper or mid tumors who have slightly more advanced disease, say very early node positive disease, and that is also T2 to T3, could think about the prospect approach that we've just talked about with chemotherapy and selective chemoradiation. In other patients with very more advanced disease, such as T4 tumors, N2 disease, or other high risk features such as EMVI, lateral pelvic node involvement, or circumferential radial margin involvement, we could think about total neoadjuvant therapy for these patients where we deliver both radiation as well as chemotherapy up front. And then patients, especially those with low-lying tumors who may require an APR, if we have a complete clinical response with this approach, we could think about watch and wait and omit surgery. Moving on to the use of circulating tumor DNA in patients with resectable colorectal cancer, we had another update from the Circulate Japan group looking at ctDNA dynamics in colorectal cancer patients. Before I go over the results, I wanted to refresh your memory about what the Circulate Japan study was. So this is actually a group of three different trials. The study that's called the Galaxy study is the screening part of the study, where patients with stage 2 through 4 resectable colorectal cancer are enrolled at the time of diagnosis, and they are monitored with ctDNA, and the assay that's used is a tumor-informed assay, Signatera, and they get this assay done at the time of diagnosis and serially through any therapies that they may get in the neoadjuvant, post-surgical adjuvant settings, and through surveillance. And patients who are ctDNA positive on the Galaxy study, some of them are enrolled onto interventional trials, including the Vega trial that is trying to ask the question whether we could safely de-escalate their adjuvant chemotherapy in patients who are ctDNA negative, and the Altair study that is asking the question if we should escalate therapy in patients who are ctDNA positive after surgery. These studies are still pending results, but the updates that we've had over the last year to 2 years are from the observational Galaxy cohort who've not been enrolled onto either of these interventional trials. So the latest update we had at GI ASCO earlier this year included close to 3,000 patients. And they updated some of their prior data with this larger data set and also with a longer median follow-up. And some of these findings that were shown were actually kind of confirmed what we already know from the Galaxy presentations as well as other studies. For instance, they showed that patients who are ctDNA positive after surgery had much worse outcomes as measured by disease-free survival with a hazard ratio of 12. And they also showed that patients who are ctDNA positive, when they get adjuvant chemotherapy, a proportion of these patients actually clear their ctDNA. And this was shown in prior presentations. But what they showed of significance this time is that in these patients who cleared their ctDNA, not everybody had a sustained clearance. Some patients appear to have cleared their ctDNA for a period, and then they turn ctDNA positive. So when you look at the outcomes of these patients and you compare them to the patients who never cleared their ctDNA, what we see is that the median disease-free survival is very, very good for patients who've had a sustained ctDNA clearance. That's the blue line that you see. And the patients who had transient clearance of their ctDNA, so their disease-free survival did improve as compared to those without clearance. For instance, in this cohort, the median was 9 months in the transient clearance cohort versus 3.5 months in those with no clearance. While this seems somewhat promising, what is really critical to look at is when you look at the 24-month disease-free survival. So how are they doing after a longer follow-up? And what you see is that in the sustained clearance, outcomes are great. The 24-month disease-free survival is over 90%. But in the transient clearance and the no clearance group, it's actually only 2 to 3% of the patients who have a disease-free survival. So clearly, it's only the sustained clearance group that are doing well with longer follow-up. And they also provided some additional data about the dynamics as to when these patients turn positive with regards to their ctDNA after transiently clearing with adjuvant chemotherapy. And what they showed was that virtually everybody had a recurrence in terms of their ctDNA by 18 months post surgery. The other piece of data that they showed and confirmed from prior presentations is the fact that in patients who've, say, finished their adjuvant chemotherapy and are undergoing surveillance, during surveillance, if they turn ctDNA positive, similar to what we've seen before, their outcomes are also pretty dismal with regards to disease-free survival, with a hazard ratio of 42, corresponding to a 24-month disease-free survival rate of over 90% in all the patients who are negative versus about 6.5% in patients who are ctDNA positive during surveillance. The bespoke study was a study conducted in the US and also an observational cohort, also used Signatera. And with a similar overarching design where patients with resectable colorectal cancer would be enrolled and would have serial evaluation for ctDNA from the time of diagnosis through any adjuvant chemotherapy during surveillance. And the results also were similar to what we noted in the Galaxy trial, in that the ctDNA status after surgery was very strongly prognostic. And patients who were ctDNA positive had a much higher risk of recurrence. What the study did also provide was that it gave us some benchmarks as to the proportion of patients who may be ctDNA positive after surgery according to the TNM stage. In stage 2 patients, it's about 5 to 6%. In stage 3 patients, it's about 20%. And what they also showed was that there was a proportion of patients in whom ctDNA cleared with adjuvant chemotherapy who were initially ctDNA positive. But similar to the Galaxy study, it is critical to see whether the ctDNA clearance is sustained versus transient, because the ones that have transient clearance have a recurrence of their ctDNA as well as their disease in around 15 to 24 months. And also similar to the Galaxy study, even during surveillance, patients who are ctDNA positive have worse outcomes with a much, much higher risk of recurrence overall. Um, a novel piece of information that the bespoke trial provided was also the patient's perspective. I mean, we're ordering these tests, but how do the patients feel about these tests, and what are their thoughts? Overall, there seems to be good engagement and acceptance from patients with regards to these tests, with improvement in their anxiety about cancer recurrence, empowering them in trying to make the right treatment decisions, leading to kind of more acceptance and wanting to do these tests in the future. So the key takeaways from both these studies, to reiterate what we've already discussed, the ctDNA positivity has very strong negative prognostic effects in the postoperative and surveillance settings. And in patients who are ctDNA positive, it's the sustained ctDNA clearance cohort that does well with over 90% disease-free survival at 2 years. Patients who have transient ctDNA clearance have maybe a slight improvement in the median DFS, but long-term outcomes continue to be somewhat limited. So I think the main takeaway is all these observational studies have shown that ctDNA is a very strong prognostic marker, but we really need some interventional trials to establish clinical utility in terms of how to use these tests. How can we better manage these patients who are ctDNA negative or positive? And that's the stand that the NCCN guidelines also take, where they say that ctDNA is emerging as a prognostic marker. However, there is currently insufficient evidence to recommend routine use of ctDNA assays in the setting outside of a clinical trial, and participation in clinical trials is encouraged.
Do you not use circulating DNA in your own practice outside a trial? Or
So
no?
it is being ordered because the test is covered by CMS, and so insurance companies pay for it. But we really don't know how to use the data from these tests, right? So if you have a stage 3 colon cancer patient who's ctDNA negative, are we comfortable today not giving that patient adjuvant chemotherapy? And similarly, in a patient who, say, is ctDNA positive during surveillance after they've finished adjuvant chemotherapy and they turn positive, sure, they have a high risk of recurrence, but what do we do? I mean, how do we manage that patient? We don't know. And that's what the NCCN is trying to say.
Well, what about node negative?
So, I think the dynamic trial suggested that stage 2 low risk patients who are ctDNA negative, perhaps in those patients we could think about safely de escalating therapy. But the NCCN guidelines, to your point, has not put that in there yet to use.
That's really interesting. I'm surprised. I'm
Yeah.
surprised I didn't know that, but that's really. I see so many people doing it. It's hard to believe, but
Indeed, and
okay.
I think that's kind of the disconnect between having an assay that's available, but the data are still catching up in terms of how to use it.
I think the one situation though I would wonder about would be again stage 2. with a negative ctDNA. I think a lot of people could be on the fence, and I don't see why you wouldn't apply it. I mean, you want more data?
So low risk stage 2, I think, is one situation where I have a discussion with the patient and say, look, it's low risk and the ctDNA comes back negative. I think it's reasonable to omit chemotherapy. So that's my practice, yes. And another setting would be where, say, if a patient is at high risk of toxicities from adjuvant chemotherapy, then maybe try to get the ctDNA test to help determine the decisions.
It's very interesting.
And I just wanted to highlight an ongoing clinical trial here in North America, the Circulate North America, which is enrolling patients with stage 2 high risk patients or stage 3 patients with colon cancer who'd be evaluated with the Signatera assay. And they would be put on one of two cohorts. If they're ctDNA negative, the cohort is asking the question of whether we can safely de-escalate adjuvant chemotherapy in these patients, randomizing them to immediate chemotherapy versus serial surveillance with ctDNA and starting adjuvant chemotherapy if and when they turn positive. If they're ctDNA positive, the question being asked is, can we escalate over the current standard of care and do more intensive adjuvant chemotherapy to improve improve outcomes of these patients who we just saw have in a good proportion of patients only have transient clearance and subsequent recurrence. Moving on to the Intercept trial, this is a study that came out of MD Anderson that looked at this question of clinical utility of these ctDNA assays. And this observational cohort enrolled patients who had stage 2 through 4 resectable colorectal cancer. And similar to the other studies that we've seen, also used Signatera. And this was obtained serially from the time of diagnosis, postoperatively, during and after adjuvant chemotherapy, and during surveillance up until the time of recurrence. And if and when the patients turn positive, the patients would have evaluation to see if they had radiographic evidence of recurrence. And those who did not have an evidence of recurrence, an attempt was made to enroll them onto interventional clinical trials geared towards these patients who are ctDNA positive but without any radiographic evidence. In the presentation at ASCO 2023, around 1,100 patients data were used. And the key take-home message was that of the patients who were ctDNA positive during surveillance, about 50% of them actually had evidence of radiographic recurrence when you do scans in these patients. And these scans could have been kind of already scans that were ordered as part of surveillance or were triggered by the positive ctDNA assay. So this kind of suggests that perhaps the current generation of assays are probably not as sensitive as we would like them to be. Maybe they're detecting these recurrences a little too late. So it's only about 50% of these patients are truly MRD positive, that is ctDNA positive, but radiographically negative. And uh, 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 these patients who are MRD positive could be enrolled onto ongoing clinical trials, and about 60% of these patients were enrolled onto ongoing clinical trials to evaluate novel therapies in this space. So, conclusions and takeaways. When ctDNA positive, I think it's important to do scans to look for any overt metastatic disease. What needs to be evaluated is if we keep doing these assays serially, are we able to pick up patients who, if they have radiographically overt disease, would they at least have oligometastatic disease that we can kind of treat and hopefully cure with locoregional therapies. And in patients who are truly MRD positive, because we don't know what to do and how to treat these patients should be encouraged to enroll onto clinical trials. And that's a huge, huge unmet need. And hopefully, in the near future, we'll have more sensitive assays and also data on how to manage these patients. Moving on to the metastatic setting and starting with the paradigm trial. This trial asked the question of in patients with RAS wild type metastatic colorectal cancer who are receiving first line chemotherapy, here it was FOLFOX, would panitumumab or bevacizumab be the better choice as the biologic agent? This is a phase 3 study conducted in Japan. And as I said, enrolled patients with RAS wild type metastatic colorectal cancer undergoing first line chemotherapy. And patients were randomized to panitumumab plus FOLFOX or bevacizumab plus FOLFOX. After the study was initiated, data around the predictive implications of sidedness came out, and that right-sided tumors would not respond to EGFR antibodies. And so the study was amended only to have left-sided tumors subsequently after that. So when you look at the overall study population, about 75% were left-sided and about 25% were right-sided. And the statistical design was hierarchical, where they looked at the primary endpoint of overall survival in the left-sided population first. And if that was positive, then they would look at it in the entire study population that included the right-sided tumors as well. So, with regards to the outcomes, overall survival did improve with the addition of panitumumab in first-line therapy as compared to bevacizumab, with stratified hazard ratio of 0.82 in the left-sided tumors, and with a stratified hazard ratio of 0.84 in the overall patient population. Furthermore, response rates also seem to have improved from about 68% to about 80% in the left-sided patient population, and from about 67% to around 75% in the overall patient population. And this translated to improved R0 resection rates in these patients with the addition of panitumumab from about 10 to 11% to around 17 to 18%. And as shown by multiple other prior studies, there was really no benefit in the right-sided patient population with the addition of panitumumab. They then followed up this large phase 3 study with a well thought out biomarker study, where they evaluated ctDNA at baseline from these patients, and they had ctDNA from the majority of patients. In the ctDNA biomarker study, they had a little over 730 patients. And they looked at the alterations in ctDNA in these patients. Remember that in the original study design, they only looked at RAS wild type. So they did not go beyond RAS to look at other alterations. So what they found with this additional analysis was that Overall, about 10% of the patients had BRAF V600E mutation, and as to be expected, the majority of these were from the right side. In addition, about 6% to 8% had additional RAS mutations, and these were both in KRAS as well as in NRAS, and this perhaps reflects some tumor heterogeneity that was not picked up on the tumor biopsies. And about 3% were MSI high. And the subsequent analysis showed that these prior improvements that we saw in terms of overall survival was limited to the patients who were microsatellite stable and RAS and BRAF wild type, both in the left-sided tumors as well as in the overall study population. So addition of panitumumab did not really help in the other cohorts. And similarly, the overall response rate as well as R0 resection improvements were limited to these patients who are microsatellite stable and RAS, BRAF, wild type. And even after adjusting for all these factors, there's no benefit for right-sided tumors. So, conclusions and takeaways from the paradigm study. First-line therapy with EGFR monoclonal antibodies in metastatic colorectal cancer patients with left-sided RAF wild-type tumors is associated with improved response rate, R0 resections, as well as overall survival. In my practice, and this is in the guidelines as well, in addition to looking at RAS and RAF wild type and also sightedness, it is also important to make sure that we are ensuring that the patients do not have HER2 new amplified tumors, because we know that this is a mechanism of resistance as well. So in patients who are left-sided and fulfill all these criteria, I do have a discussion with my patients about starting with an EGFR antibody over bevacizumab.
Can you try to track the biology of how HER2 would, interact with this EGFR pathway?
So the HER2 pathway, when amplified, I think causes resistance to the EGFR antibodies by really bypassing the EGFR receptor activity.
Oh, that's interesting.
And so one of the reasons to really consider using EGFR antibodies in frontline is because increasingly we're accumulating data that this resistance to EGFR therapies is reversed over time. So if you start with a tumor that has sensitivity to EGFR antibodies, that's the panel on the top left, and you treat them with EGFR containing regimens, and over time they may develop resistance. And this could be because there are the development of clones that have genomic alterations that portend resistance to these antibodies. So at that time, when they've developed resistance, if you take them off of the EGFR containing therapies and put them on other therapies, that is, in a sense, you're giving them an anti-EGFR treatment holiday, the EGFR antibody sensitive clones repopulate, and so you could go back and re-challenge these patients with these therapies later. And there has been work that was done that looked at both the types of alterations that happen. And what was shown was that these alterations that happen are mostly in the RAS-RAF MAP kinase pathway. And what was noted was that there tend to be multiple alterations happening at the same time. So it's not limited to just, say, HER2 new amplification or RAS mutation. It could be three or four different alterations. In fact, the median number of alterations were four in a study that looked at this. However, what is important to note is that there is an exponential decay of these alterations over time with a half-life of around 4 to 4.5 months after discontinuation of EGFR therapy. So there were several trials, phase two, small sized, that really looked at this question of rechallenge with EGFR antibodies that were reported over the past few years. And the study that was presented at ESMO last year did a pooled analysis of four of these studies with a total of about 114 patients. And they confirmed what was noted individually in these patients, and that there is some response with a response rate of around 17 to 18%. And remember, these are truly refractory patients who progress through pretty much everything. So a response rate of 17% is reasonably significant. And with a median progression-free survival of 4 months and overall survival of about 13 months or so. So takeaway, EGFR rechallenge is a very reasonable option, but after checking ctDNA for resolution of any resistance mechanisms that these tumors may have developed with prior therapy. There was a study that looked at kind of acquired alterations on first-line chemotherapy with EGFR antibody, that is cetuximab, in advanced colorectal cancer. So this would be somewhat similar to the paradigm study. And the authors used the ctDNA samples from the CALGB SWOG 80405 study. To refresh your memory, the SWOG 80405 study had patients who had metastatic colorectal cancer, first line, who were KRAS wild type. At the time of doing the study, the implications of extended RAS were not known. And patients received first-line chemotherapy. The chemotherapy backbone was per treating physician's choice, and patients were then randomized to receive either cetuximab or bevacizumab. A little over 1,100 patients were randomized with a primary endpoint of overall survival. So, in the current study, what the authors did was that they identified about 130 patients who had ctDNA samples and at baseline had extended RAS wild type and also did not have other alterations that may predict resistance to EGFR antibodies. And then they looked at kind of serial samples with ctDNA and looked at how the ctDNA profile changed with therapy, both in the cetuximab arm as well as the bevacizumab arm. And so they looked at the alterations for each mutation, for instance, KRAS, NRAS, BRAF, and so on. They also looked at amplifications as well. And then they kind of did a pooled analysis of all these kind of alterations, which is what I marked with the blue arrows there. So the cetuximab arm and the bevacizumab arm. So these were the number of the proportion of patients who had alterations on serial sampling. And they compared that to historical data from later lines of therapy as to how alterations occur with EGFR therapy in later lines. What they found was that, to their surprise, in these first line patients, actually, these tumors were not developing a whole lot of alterations with therapy with cetuximab. In fact, it appeared that perhaps there was a slight trend towards the patients who were receiving bevacizumab having more alterations with therapy in this the MAP kinase pathway, which is surprising. This is very much in discordance with what we noted previously, and also, as we can see in this figure, where the patients on later lines of therapy with EGFR antibodies have a much higher chance of developing resistance alterations. This is very much a hypothesis generating study in that they only had 130 patients, but nevertheless raises the intriguing possibility that resistance to anti-EGFR therapies is different, the underlying mechanisms in earlier lines of therapy versus later lines of therapy. Why that is, how that happens, we don't know, but still requires more validation and further investigation. Moving to the refractory setting, the Sunlight trial was a phase 3 study of TAS-102 with or without bevacizumab in the third line setting in patients with metastatic colorectal cancer. In this global study that was open label, patients with metastatic colorectal cancer who had received at least 2 prior regimens with progression were randomized to TAS 102 alone or TAS 102 in combination with bevacizumab. The primary endpoint was overall survival, and about 490 patients were enrolled onto this trial. Just a key pertinent criteria with regards to the patients who were enrolled. About 75% of the patients received prior anti-VEGF antibody, and about only 25% actually received anti-VEGF antibody in both of the prior lines. The study did meet its primary endpoint with improvement in overall survival, with median overall survival improving from about 7.5 months to around 10.8 months, corresponding to a hazard ratio of 0.6. Similarly, there was an improvement in median progression-free survival as well, with a hazard ratio of 0.44. With regards to the adverse effects, these were to be expected, keeping in line with the known side effect profile of TAS-102 that tends to cause myelosuppression, and bevacizumab that tends to cause vascular adverse effects, especially hypertension. The one of the key secondary endpoints was looking at time to worsening of performance status that was defined as worsening performance status of 2 or more. The eligibility criteria was limited to those with 0 and 1. And what they showed was that the time to worsening of ECOG-PS improved with TAS 102 plus bevacizumab from about 6 months to 9 months with a hazard ratio of 0.54. They then looked at the subset of patients who had their PS maintained. So these are patients who did not have worsening of their PS, and these were about 90% of the patients who at discontinuation still continued to have a PS of 0 to 1. And what they showed was that the drug was very effective in these patients as well, with both overall survival and progression-free survival being better in these patients. So what does this mean clinically? I think what this tells us is that these patients who have a good PS, they could go on to get other therapies, thereby improving their overall survival. So takeaways, TAS-102 plus bevacizumab significantly improved overall survival and progression-free survival compared to TAS-102 alone in the third line. Toxicities were consistent with prior experience with these agents. And the key takeaway, I'd say, well, at this point, based on these data, TAS-102 plus bevacizumab should be chosen over TAS 102 unless there are strong contraindications for anti-VEGF therapy. And it, in fact, has since been approved by the FDA for third line setting. Moving on to the Fresco 2 trial. So this was a trial in the refractory setting that evaluated fruquintinib. Fruquintinib is an oral tyrosine kinase inhibitor of VEGF receptors 1, 2, and 3. And eligible patients for this trial had received all available therapies, and this included cytotoxic chemotherapy and an anti-VEGF antibody, and as appropriate, EGFR antibodies, as well as immunotherapy or BRAF-directed therapies. In addition to all this, they should have also received prior TAS 102 and or regorafenib. Close to 700 patients were randomized 2-1 to fruquintinib versus placebo with a primary endpoint of overall survival. Key factors with regards to the patients who were enrolled, they received a median of 4 prior lines of therapy, and almost everybody received a prior anti-VEGF antibody, and prior TAS 102 in about 52%, both agents in about 40%, and prior regorafenib in about 10%. The study did meet its primary endpoint with improvement in overall survival from about 4.8 months to 7.4 months with a hazard ratio of around 0.68, and improvement in progression-free survival from about 1.8 months to 3.7 months with a hazard ratio of about 0.32. With regards to the toxicities, these were consistent with the anti-VEGF activity of this drug, with hypertension, asthenia being the most common side effect. The typical side effects that we tend to associate with regorafenib, such as elevated LFTs, hand-foot syndrome, were not very common with this agent. And there was a subsequent subgroup analysis that was done that looked at the efficacy and activity of this drug based on the number of prior lines of therapy. As I mentioned, these patients were very heavily pretreated, and so the subgroup analysis looked at patients who were less heavily pretreated, that is, less than 4 or fewer lines of therapy, versus those who had received more than 4 lines of therapy. And overall, the efficacy was consistent in both these cohorts, and improved both overall survival as well as progression-free survival, irrespective of prior number of lines of therapy or type of treatment. So, in conclusion, fruquintinib did improve overall survival and progression-free survival in patients with refractory metastatic colorectal cancer, and toxicities consistent with prior experience with this agent as well as other anti-VEGF therapies, and overall appears to be well tolerated. The FDA did approve fruquintinib both for third line as well as fourth line. That was based on this data as well as another trial that was done in China that was conducted in the third line. So the FDA took into account both trials and approved it for both third and fourth line setting, and should be considered as a an option for eligible patients.